Okay, so now we gave you general idea of the approach to diagnosis and treatment of acute and chronic leukemia. Now I want to talk a little bit specifically about each form of leukemia. First, AML, because he's going to see a lot of AML patients on the leukemia ward. How do you classify AML? There's an old classification that you will find mostly in your textbooks, and still a lot of older leukemia doctors use this classification. It's called the French-American British classification or FAB classification, and it's mainly a morphological classification. So it looks at how the cells look like and classifies the different leukemic subtypes based on the morphology of those cells. It has 7 different types, and they go from M1 to M7. M1 is least differentiated, and while walking down to M7, cells get more differentiated. So M1 without any differentiation, M2 has some maturation, M3 is important because it is your APL, okay? Hypergranular, has hour rods, promyelocytic leukemia. M4 is myelomonocytic. M5 is important too because it's monocytic, okay? And there's certain characteristics of monocytic leukemia that are worth remembering. First, gingival hyperplasia. Remember looking in the mouth of this patient and finding hyperplasia in the gingiva? This is often happening in monocytic leukemia. Also, significant CNS involvement. Okay, classically we think of CNS involvement in lymphocytic leukemia and not myeloid leukemia. But patients with M5 leukemia or monocytic leukemia have CNS involvement too. And that makes a huge difference in terms of treatment options for those patients. Okay, normally M5 patients need CNS chemotherapy, while other patients with acute myeloid leukemia, which are not M5 leukemias, do not need CNS chemotherapy. M6 erythroid leukemia and M7 megakaryoblast leukemia. Okay, so if remembering anything of the FAB classification, remember M3, APL, and M5 monocytic leukemia. Mostly otherwise, you can forget it. Okay, it's not the classification that is used anymore. The newer classification is called the WHO classification, and in contrast to the French-American British classification, does not focus on morphologic criteria, but the genetic makeup of those cancers. Okay, so it goes more into personalized medicine, really looking at the different genetic subclasses of leukemias. First one is AML with recurrent genetic abnormalities. So we look at defined structural abnormalities, translocations, inversions of chromosomes. We look at gene mutations. Mostly 3 genes are of major importance. We're going to talk a little bit about those 3 genes. It's NPM1, FLT3, and CUP alpha. You will hear those genes quite often on the leukemia ward. Then AML with MDS-related features. What does that mean? MDS stands for myelodysplastic syndrome, and it's a precursor of AML. So it means cells are not like blast-like, but they're looking dysplastic. They're not having a normal morphology. AML that arises out of MDS normally has a very poor prognosis. Similarly, therapy-related AML. So classically, a woman with breast cancer was treated with anthracyclines and now develops AML. This is also a very poor prognosis subtype. Okay, those patients do very poorly. So if therapy leads to AML, think of a poor prognostic subtype. Lastly, AML that is not otherwise classified. So it's neither AML with genetic abnormalities nor MDS AML or therapy-related AML. This AML normally gets still classified by morphologic criteria by the French-American British classification. Okay, so we talked a lot about different prognostic subtypes of AML. Let's get a little bit deeper into this because I think it's very important. This is how survival curves of AML can look like. Okay, and they get classified in high-risk patients, right here, low-risk patients, here with better survival, and intermediate-risk patients. Okay, and their survival differs quite a bit, as you can see. Okay, if you look at survival of half the patient, or when 50% of the patients died, it matters significantly. Okay, this is about 50% here, 50% here, and 50% here. So you see the different times of survival of 50% of your patients. Okay, so if you have a patient with AML, you really cannot treat AML patients all the same and give them all the same therapy. It really matters what subtype they are. How do we classify different subtypes? First, low-risk subtypes. Okay, those are your patients with pretty good survival. Classically, patients with translocations that you find in your USMLE books. Okay, so your APL patients with a translocation between chromosome 15 and 17, or between chromosome 8 and 21, or inversion of chromosome 16. Those are normally all pretty good subtypes of leukemia. High-risk subtypes of leukemia. Those are patients who do pretty poorly. They are patients with complicated karyotypes. Okay, so that's classically the patient you don't see in USMLE books because they can have pretty much everything. Often they have missing chromosomes like chromosome 5 and 7, or they have very complex karyotypes like triploides, meaning every chromosome is not there only twice but 3 times, or trisomies, etc., etc. So if it's not fitting your translocations that you see in your USMLE books, but there's still kind of more than one abnormality in your karyotypes, would be called a complicated karyotype, and those patients are doing pretty poorly. So low-risk patients, again, you wouldn't give hematopoietic stem cell transplant, okay? You give them chemotherapy as consolidation therapy, which is a less aggressive therapy. High-risk patients, they get stem cell transplants. They get the most aggressive therapy we have because their survival without it is so poor. So now we have a huge group of intermediate risk patients. They're neither high nor low risk. Let's say they don't have typical translocations, but they also don't have a complex karyotype. They basically have no abnormality in their karyotype. What do you do with those patients? Those are the kind of patients where you look at gene mutations, okay, to decide do they belong to the high risk or the low risk karyotype. Here's the survival curve defined for gene mutations. As you see here, you still have your intermediate risk subtype, you have your unfavorable cytogenetic profile, and you have your favorable cytogenetic profile. And now what we really want to focus on is the intermediate subtype, okay? Does this go to the low-risk subtype, or does it go to the high-risk subtype? And this you can see in blue here for the low-risk and red for the high-risk subtype. Okay, so gene mutations are used for this. We normally look in for high-risk, unfavorable gene mutations. So those patients, again, just as the unfavorable complicated karyotype patients get hematopoietic stem cells. FLT3 ITD, internal tandem duplication, is the main mutation to remember for you guys. FLT3 is a bad sign. Favorable gene mutations do not require hematopoietic stem cell transplant because they do really, really well. As you see here, those are the intermediate risk patients with favorable gene mutations, okay? They even seem to do better than those patients with favorable cytogenetic profiles. So keep in mind, those patients are doing very well. They don't need a hematopoietic stem cell transplant. What gene mutations confer a favorable subtype? NPM1 and CBP alpha. So if you remember 3 genes in leukemia, I want you to remember FLT3 as a bad player and NPM1 and CBP alpha as good players. So now, similar to the flow cytometry part of this lecture, you understand the complicated language of leukemia doctors a little bit better. So let's say the attending tells you, so we have this patient admitted with AML, didn't have classic translocations like chromosome 15 or 17, had no inversion 16. You know now, well, okay, so that's not good because he doesn't have the good translocation that you want to have. But then your attending goes on. He also didn't have a complex karyotype, so we excluded missing chromosome 5 or missing chromosome 7. Also didn't have any triploides, etc. You note again, that's good. At least he doesn't have like any clear high-risk karyotypes. Then the attending goes on, tells you, we looked at gene mutations, no FLT3, but positive for NPM1 CBP alpha. And now you understand that this is a good sign because FLT3 is a bad player and your patient doesn't have it, and NPM1 CBP alpha is a good player. So this is really the future of leukemia medicine here because it goes into a into an aspect of personalized medicine, to really look at every patient as an individuum and try to figure out the prognosis of this patient first and then the best treatment. Does this patient need toxic hematopoietic stem cell transplant to increase the chances of survival? Or is he better off going with chemotherapy and not going for a stem cell transplant because his leukemia has a good prognosis? Okay, so how does this translate into leukemia treatment? On the left, we have the different subtypes of AML. We have low risk, we have high risk, and we have the entire box of intermediate risk. We divide the treatment into induction chemotherapy, consolidation, and hematopoietic stem cell transplant. Let's start with induction because it's super simple. All of your patients, low, intermediate, or high risk, gets the same induction chemotherapy. Okay, it does not really matter whether they're low, high, or intermediate risk patients. Induction chemotherapy is classically 7+3, and you will hear that a lot on the leukemia ward. It means you get cytarabine or Ara-C for 7 days, and then you get Ida or daunorubicin for 3 days. And that makes up the 7+3. Again, remember, all patients, independent of their karyotypes, mutational status, etc., get induction therapy 7+3 if they're fit enough to tolerate it. The differences really are in the consolidation therapy, either with chemotherapy or hematopoietic stem cells. And keep in mind, consolidation therapy, again, is a less toxic treatment, and hematopoietic stem cell is a more toxic treatment. So consolidation therapy is normally preserved for low-risk patients, while hematopoietic stem cell transplantation is preserved for more high-risk patients. Okay, those are those kind of patients. What is consolidation therapy? Again, a word that you will hear a lot is HiDAC, and it stands for high-dose cytarabine. Okay, so it's again the cytarabine or Ara-C that you already know from your 7+3 induction chemotherapy, but at a higher dose. So, for a low-risk patient, gets induction therapy like every patient, then gets consolidation therapy 3 or 4 cycles here of HiDAC and does not need a transplant. A high-risk patient, complex karyotypes, FLT3 mutation, does get induction chemotherapy, just like everybody else, then maybe gets 1 cycle of consolidation therapy, but soon goes to a hematopoietic stem cell transplant. If you're in your intermediate risk group, you have to see is this favorable mutations or unfavorable mutations. Both of them get induction chemotherapy, the same. But the big difference is for favorable mutations, you go down the route of chemotherapy, it's consolidation therapy, and for unfavorable mutations, they have to go just like as high-risk patients for a hematopoietic stem cell transplant. One specific subtype that we're going to talk a little bit more in the complications of leukemia is APL. Okay, APL is kind of very different because it goes with a different induction chemotherapy and a different consolidation therapy using ATRA or arsenic. Okay, both for induction and consolidation. Okay, perfect. So now you basically understand the treatment of AML. Again, to summarize, the treatment heavily depends on the type of AML. Again, to summarize, induction therapy is the same for every different type of AML. But after you're done with induction, it becomes a highly personalized chemotherapy, depending on your genetic makeup. And you will either get consolidation chemotherapy or hematopoietic stem cell transplant, depending on whether you're good or poor prognosis.